one aspect of hematology, of course, is the cells and RBC, WBC platelets, high, low because of various benign issues. The second aspect is hemonc, which is leukemia, lymphoma, myeloma. The third part of our work is essentially clots. So either abnormal clotting, which we call as thrombosis, or abnormal hemorrhage. And last is a stem cell transplant. So there are four aspects to hematology, and we are now coming to the third aspect, that is coagulation. So we will talk about normal hemostasis. How does a clot form? And then we will have a discussion on why do certain patients have abnormal hemorrhage? What is abnormal hemorrhage and why do they have, and how do we evaluate it? As always, this is going to be a very practically oriented discussion. We are not going to get into major details of theories, etc. Just take you through the story of our understanding of coagulation. Now, the core concept of coagulation is that blood in the body, blood flows through pipes. These pipes are arteries and then arterioles and capillaries and venules and veins. All right, the pipes, blood flows through pipes. Heart is the pump at the center of it. So the heart will pump the blood which flows through the pipes. Now for blood to flow through the pipes, it has to remain fluid. If blood becomes solid, that means if it clots, it cannot flow. And if blood does not flow to any part of the body, there is ischemia, which depending on the body part, can lead to anything from mesenteric ischemia to stroke to AMI to pulmonary embolism also. So we want the blood to remain constantly in the liquid form so that it can flow seamlessly, smoothly from our fetal stage until we die. However, we are all aware that pipes can burst, pipes can break. We've all seen or at least heard of a water pipe in your city bursting, and you've seen how water gushes out when the pipe bursts, right? And similarly, the arteries and capillaries in our body can also break, they can also burst. And that happens, body has to have a mechanism to stop the blood flow. Contrary to what happens in our cities and towns and villages, when a water pipe bursts, there is no automatic system to close that hole. But in our body, whenever an artery, vein, etc. breaks, there is an automatic system to close that hole so that we don't bleed too much. So the blood is kept fluid in a liquid anticoagulant. So blood has an entire system, bunch of proteins, excuse me, and these proteins keep it in the liquid state, anticoagulants. However, whenever the blood vessel breaks, at that point, what was understood that finally we need this reaction to happen. You see this reaction, which means that prothrombin has to convert to thrombin. Now, the beauty of biology in coagulation is all the proteins are there. They're floating around in the blood, but they are in a precursor stage. So you have prothrombin, right? And there is another enzyme which was not known at that time. There is another enzyme. The job of this enzyme is to cut part of prothrombin so that prothrombin becomes thrombin. Okay, factor 2A activated. Prothrombin is now activated to form thrombin. So the precursor protein is there. It's just that part of it is chopped off so that it becomes active. Now what thrombin does is it will take fibrinogen, again a precursor protein, and convert it to fibrin. Fibrinogen converted to active fibrin. And fibrin is like a thread. It's like a strand. And multiple threads of fibrin will then entangle to form a clot. Okay. So this is the last step of coagulation. Something will convert prothrombin to thrombin. Thrombin will convert fibrinogen to fibrin, and fibrin strands will entangle, and other blood cells, so RBCs and platelets and WBCs, will also get entangled in these threads, and that will form a clot. This was understood. What was not understood is that it's not that straightforward, that there are multiple proteins. Some of them will help and some of them will slow down coagulation. Okay. And that then was known as the cascade model. Now, cascade means waterfall. Cascade means waterfall, one goes to another, second goes to third, third goes to fourth. And we have all seen this cascade model, studied this in our medical graduation curriculum. But again, what matters is whatever creates this, okay? It was thought that there are two pathways. There is an extrinsic pathway and there is an intrinsic pathway. And what was understood that in the extrinsic pathway, the blood vessel, you see this? This is the blood vessel, the endothelium of the artery or vein or venule, that this gets damaged. Okay? This endothelium gets damaged. And when it gets damaged, when there is a break, below the endothelium, you have some protein. And this is called as tissue factor, TF, tissue factor. So the beauty is, as long as there is no break, the endothelium, vascular endothelium, whether artery, vein, capillary, it is smooth. Okay, it is smooth and it does not allow clotting. Blood can flow like a liquid. But if it breaks due to whatever reason, then the endothelium will break, and below the endothelium, in the subendothelium, in the tissue, you see now the tissue is exposed. What happens is there is some protein called as a tissue factor. Now, this tissue factor will then alert the blood and kickstart the cascade model, right? So the tissue factor will attach to factor 7, which gets activated, blah, 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 blah. And ultimately, you get the same thing. Prothrombin to thrombin, fibrinogen to fibrin, fibrin strands. In the fibrin strands, RBCs, WBCs, platelets will get entangled and a clot will be formed. Here, there was one more additional knowledge which came in, that this enzyme, the thrombokinase, is actually factor 10 and 5 joined together. That works as an enzyme and converts prothrombin to thrombin. So you see now more and more complexity is coming along. However, for about 20 years or so, there were a lot of things which were not explained, a lot of things in coagulation which were not explained. I'll give an example. You look at the intrinsic pathway, it was thought that factor 12 is the first one to get activated in the intrinsic pathway, and 12 becomes 12A and so on and so forth. But in hematology, we routinely see that patients with factor 12 deficiency don't have any bleeding. How is that possible? If the cascade model says that there are two pathways, extrinsic and intrinsic, extrinsic is triggered by tissue factor and intrinsic is triggered by factor 12, in patients who don't have factor 12, there should be no clotting, there should be bleeding. So, there were several such clinical conditions which are not explained, right? And we kept on reading more and more research as different groups around the world, groups of researchers started figuring out things one by one, until we came to this. And this is the current model of coagulation. It is called as a cell-based model. Cell-based model. Now, why is it called cell-based model? And this is fascinating. This came in about 2004, right? And nowadays, we understand that this is our best understanding of coagulation. What happens here? The same thing. The vascular endothelium is broken. Tissue factor is exposed. This tissue factor starts working with factor 7. Okay. And then factor 7, 9, 10, blah, blah, blah. and ultimately it leads to the same fibrinogen fibrin. But the most important thing is after the initial phase, initiation, remember all of this is happening in a pipe where blood is flowing. So imagine if there is a breach here and the tissue factor is released and it activates coagulation. This should get washed out by the blood, right? Blood is constantly flowing. So even if this tissue factor activates whatever coagulation protein, it should just get washed out. How does the clot stay there? How does the clot stay there? That's because what was understood that after the initiation, the most important thing that comes in is platelet. Platelet, okay? In this, what we learned is platelets get activated. And platelets are these wonderful balloons. Platelets are nothing but cell membrane with some cytoplasm. There is no nucleus. And the cell membrane can push clotting forward. It can accelerate clotting. So the platelets get activated. And this platelet surface, the cell surface, is where these activated coagulation proteins start sticking to it. You see this? This is the platelet cell membrane. Everything that is developing here starts sticking to the platelet cell membrane.
ನಾನು ಬಿಡ್ತೇನಂತ ಬೇಕಂತ ತಂದು ನಿಲ್ಲಿಸುದಲ್ಲ, ನಂಗೆ ಕಷ್ಟ ಆಗ್ಲಿ ಹೇಳಿ ಗೊತ್ತಾಗ್ತಾ ಉಂಟು ನಂಗೆ.
I'll just mute everyone. Okay. So it is these platelets which are getting activated and they stick to each other, they aggregate, they stick to the vessel wall, and all the clotting proteins actually stick on the platelet surface, and that's how the clot is formed. That's how the proteins are not washed away by blood which is flowing. Okay. So it is this cell membrane, the cell surface, which actually serves as a platform. It's the platform where all of these coagulation proteins get attached and they actually form a fibrin clot. So this is the current model, cell-based model of coagulation. So with this in background, let us see what happens. How do we assess patients who come to us with abnormal bleeding? Okay, there's normal bleeding and there is abnormal bleeding, right? If I get an injury, there will be bleeding for some time and then it stops on its own. That's normal bleeding. Normal menstrual flow, normal blood loss during pregnancy, right? If I brush my teeth hard and I have gingivitis, there'll be some little bit of blood. That's normal bleeding. What is abnormal bleeding? Now, when we come to abnormal bleeding, we first think about what is the pattern of bleeding, what exactly is happening. And we divide hemorrhage, we divide hemorrhagic issues into two patterns. Either it can be a bleeding disorder or it can be a clotting disorder. Bleeding disorder, clotting disorder. Bleeding disorder means that it's superficial bleeding. Superficial. Skin, mucosal, so there can be petechiae, ecchymosis, mucosal bleeding from the teeth, urinary tract, um, uh, menorrhagia. These are all mucosal bleeds. Gastrointestinal bleeding, mucosal bleeds, right? This is called as these are called as bleeding disorders. Now, when we look at bleeding disorders, quite often patients come to us with this, and they come to you with this. They come with these spots. If the spots are very tiny, we call them petechiae. If they are slightly bigger, we call them purpura. And if they're more than 1 centimeter bleeding in the skin, we call it an ecchymosis. So essentially bleeding in the skin or the mucosa, patients can have what we call as wet purpura. Wet purpura means purpura on the mucosal surface, on the tongue, the palate, the gingiva, etc. Now, these bleeding disorders with mucocutaneous superficial bleeding are a platelet-related problem generally. What can happen to the platelet? Either the platelet numbers may be low or the platelets may not be working. That means the numbers are there, but they are not functioning. There's a platelet function defect. Yeah. So what test will you do for this? You do a complete blood count. You look at the platelet count. Excuse me. If the platelet count is low, then you evaluate for thrombocytopenia. If the platelet count is normal and you still have mucocutaneous bleeding, you have to look at the platelet function. And the clinical way of looking at it is by doing a bleeding time. Bleeding time, so prolonged bleeding time. Okay. How do we treat this? By giving platelets. Simple, right? Examples are Glanzmann's thrombasthenia, Bernard-Soulier syndrome. These are genetic syndromes, congenital syndromes. Acquired would be aspirin, right? Aspirin overdose. It will not allow the platelet to work. So that is what happens in bleeding disorders. Now let us see what happens in clotting disorders. In clotting disorders, the platelet counts are fine, and the problem is with the coagulation proteins. You know, all of this factor 2 and all that. Now, whenever the coagulation proteins are a problem, the bleeding is deep. It is internal. It can be within the muscle. So there can be muscular hematoma. I had a patient with hemophilia A who had such a massive hematoma on in the pectoral muscle. Can you believe it? Usually our patients with hemophilia get bleeding in the paraspinal muscles. Excuse me. We call that a psoas bleed because it's in the psoas muscle, iliopsoas muscle. They can get bleeding in the thigh muscles. So there are deep muscular hematomas like this. You see, this is in the thigh muscle, or there is bleeding in the joint space, hemarthrosis. Again, we see this in hemophilia A or B, where factor 8 or factor 9 is deficient, respectively. So, clotting disorders lead to deep muscular bleeding or joint bleeding. It's related to coagulation factor deficiency. The tests that we do are prothrombin time or activated partial thromboplastin time, and these are prolonged. The bleeding time is going to be normal. The platelet count is going to be normal. And to treat, we have to give coagulation factor. And there is a product available in blood banks called fresh frozen plasma. You see, FFP is the one treatment for all coagulation factor deficiency. Fresh frozen plasma has all coagulation factors, everything. So if you don't know what is happening, you can comfortably give FFP. No problem. It has all the coagulation factors. In certain conditions, we give what is called as cryoprecipitate, which is also made from FFP only. Examples of such coagulation factor deficiency, like I said, hemophilia A or B, factor 8 or factor 9 deficiency, respectively. So these are the clinical patterns of hemorrhagic disorders. We then ask the patient, so when somebody comes to us with bleeding, we think, okay, is it mucocutaneous? Is it deep bleeding? Then we ask, okay, how bad is the bleeding? Did you notice it by chance? Or is it that, many times today, patients have no bleeding, but on routine blood test, it is found that bleeding time is prolonged or PT-APTT is prolonged. And they get referred to us for evaluation of a hemorrhagic hemostatic issue. So many times patients may have no clinical symptoms, but they just come with this. And then we check, all right, your PT-APTT is prolonged, bleeding time is prolonged, but is it significant? Significant means platelets are more than a lakh and bleeding time is normal, 1.1 platelet, 1.2 lakhs, etc. We say, hey, maybe this is not very significant. Or even if the PT-APTT is prolonged, if it is more than 1.5 times normal, 1.5 times normal. What this means is if the normal in that lab, if they say that PT normal is 12 to 15 seconds, for example, and they give you an INR. If the INR is 1.3, don't worry. Usually it will not lead to bleeding, okay? So significant prolongation of PT-APTT is if the INR is more than 1.5 or APTT is more than 1.5 times normal. So if your lab says the normal range for APTT is 24 to 28 seconds, for example, then 28 into 1.5. So APTT is significantly prolonged only if it is more than 42 seconds in that lab. Okay. So significant is only if PT more than 1.5 times normal. One classic clinical scenario for this is in patients with chronic liver disease, right? So alcoholic cirrhosis or anything. They will have a prolonged PT. The INR may be 1.4, 1.5, 1.7, but they have no bleeding. These are typically the patients who are incidentally detected and they generally don't have major coagulation issues, right? Then there are patients who will have milder hemostatic problems, moderate and severe. So no mild, moderate, severe. There are four grades of severity of a hemostatic problem. What is mild? Mild meaning, okay, there is bleeding on severe injury or post-operative bleeding. That means they say that, I had a road traffic accident and the doctor calls you saying, look, I have a patient with road traffic accident, but the bleeding is unusual. We are trying compression, we are trying everything, but it's not stopping. Before this, he's never had bleeding. Okay. So now this is a patient who's never had bleeding in the past. And now there is excessive bleeding after a severe injury only. That is more likely to be a mild hemostatic issue. Similarly, women going through pregnancy and labor and delivering, they get postpartum hemorrhage. And the gynecologist will call saying, hey, Sachin, I have a patient, never had any problem in the past, but postpartum there is bleeding, the uterus is contracting well. And then I say, okay, normal labor and delivery is a very strong hemostatic challenge. So on this, if there is bleeding, I will say, okay, maybe she has mild to moderate bleeding. And let me explain some more things to you. So these are patients who have no spontaneous bleeding, right? These are patients with milder hemostatic problems like mild hemophilia A or B. Now, let me tell you something even more amazing about biology. I told you that we have coagulation proteins floating in the blood, right? And if we say that the normal level of coagulation protein is 100%, okay? If we say the normal level is 100%, 100% is something that our body doesn't need. Nature has given us a surplus of everything. Like, I don't need a hemoglobin of 12 or 13. I don't need so many muscles because I don't run marathons, right? I don't need 1.5 lakh platelets. Thus, I also don't need 100% coagulation factors. In fact, until the factor level is above 50%, there is no bleeding. No bleeding. The definition of a coagulation problem is your factor level starts going below 50%, 49, 48, 47. You see, so we have double the amount of coagulation factor floating around in the blood, and 5% to 50% of coagulation factor is only mild hemostatic issue. But then what is moderate? Moderate is excessive bleeding on minor trauma. Means the parents bring a child saying, he had a tooth fall and the bleeding is not stopping for the last 3 days. And the dentist has also tried to suture, but it has not stopped. But doctor, before this, he never had a problem. We don't know what has happened. Okay. So that's a moderate coagulation problem because a dental extraction or a tooth fall in childhood is not a major trauma, right? It is a minor trauma, but there is bleeding. So major trauma, bleeding, mild coagulation. Minor trauma leading to bleeding, now we are coming to moderate. Yeah. Again, patients with moderate coagulation, hemostatic issues do not bleed spontaneously. The family will say, no, no, he's never had any problem. And this is what we see in moderate hemophilia A or B, which means you see 5 to 50 to 5% is mild. When it goes below 5%, up to 1% is moderate. So you see in a hemophilia A patient with factor 8 level of 2% will only have moderate bleeding, right? 2% will only have moderate bleeding. It is only when it goes below 1% that severe symptoms start. And in severe symptoms, forget injury, even without any injury, there is spontaneous bleeding. Means the baby is fine at about 5, 7, 8, 10 months. When the baby starts crawling around, they start getting swellings in the knee, right? So activities of daily living will lead to bleeding, not even injury, just spontaneous bleeding. Our hemophilia patients will say that, doctor, I was fine. I was sitting in the chair and suddenly my legs started swelling. No injury, no fall, no football, nothing, right? So that's a severe coagulation problem. This happens when the factor level goes below 1%. Okay. So now let's go reverse. Severe coagulation problem, spontaneous bleeding. Moderate, no spontaneous bleeding, but with some minor trauma, it will bleed. Mild coagulation problem, no spontaneous bleeding, and severe trauma is required to cause excessive bleeding. And then there are patients who only have a number which is abnormal. The PT is abnormal, APTT is abnormal, but they don't have any problem. So these patients truly don't have any coagulation problem. So this is the severity of a hemostatic problem. So when a patient comes to us, we say, okay, mucocutaneous or deep bleeding, mild, moderate, severe, or just the blood test is abnormal without any bleeding, right? And we take the details of that history, how, if there is any bleeding, how did it happen? Was the bleeding spontaneous with minimal injury, major injury? Did the bleeding stop on its own? Or did the surgeon have to suture the gums because there was excessive bleeding from tooth fall? Or did the doctor feel that, no, no, I'll have to give you blood products, FFP platelet, without that bleeding is not stopping? That's serious bleeding. We ask, okay, what has happened in the past? Have you ever had such bleeding, right? And what happened at that time? What about any previous surgeries? Did you have an appendicectomy? Did you have a tonsillectomy? At that point, did you have excessive bleeding or prolonged bleeding? Sometimes the bleeding will happen late. That means the surgery is done today, but 2 days later there is bleeding, right? That's called delayed bleeding. That's a classic feature of factor 13 deficiency. Very rare, but very classic. We ask, did it bleed so much that your hemoglobin dropped, that your doctor had to give you blood, or they had to give FFP cryo to, improve the coagulation profile? We ask them sometimes, they will say, yeah, yeah, I had bleeding and doctor give me factor injection. That time we know that maybe the patient was diagnosed as a factor deficiency in the past. So that's also part of our history. In women, we can ask about menorrhagia. And you'll be surprised how many women with who have severe menorrhagia and don't have PCOS or any other cause, about 1% of them might actually have von Willebrand disease, undiagnosed von Willebrand disease, and they bleed and they are chronically iron deficient. In women, we also ask about childbirth. Was there excessive postpartum bleeding? If a lady says, no, doctor, I had a cesarean section and there was no bleeding, done, then that means that lady does not have a congenital hemostatic disorder. A woman who has gone through childbirth, who has gone through cesarean or even normal vaginal delivery and has not had unusual bleeding, has not had an inherited hemostatic problem. They may have acquired later something else, but inherited, ruled out. Okay. Childhood, we ask, was there any delayed bleeding from umbilical stump? This is also characteristic of factor 13 deficiency, joint swellings, prolonged bleeding after tooth fall. What medicines are they taking? You'll be surprised how some antihistaminic medicines can cause bleeding, right? Very rare and very mild, but it can happen. And sometimes, we just forget that patients are on aspirin. And aspirin, I mean, my mother, this happened. My mother had coronary artery disease, and she told me that, I gave my cholesterol test last week, and after that, I had a black patch on the from where they put the needle, and that patch stayed for 7 days. And I thought, if the she said no, and it was a good person who took the sample. There was no problem. And I was thinking, why did you have a bruise in the antecubital fossa after blood sampling? That's when I realized she was on dual antiplatelet. She was on aspirin and clopidogrel, right? So it's important to take this history in anybody who comes with a bleeding issue. I had a patient who forgot to tell that he was on warfarin because he said, yeah, yeah, I'm taking warfarin for last 10 years, doctor. He had some thrombosis, DVT or something, and I'm just taking it in. And I thought, what is there to tell? And he had come to us with some bleeding, and we said, "Mon, boss, your warfarin is causing bleeding, right? So it's very important to dig into history, ensure that we figured out what is the kind of bleeding, how bad was it, what was the level of trauma, were there any drugs, were any transfusions required to stop the bleeding. Yeah. Now, once we have taken this history, we do screening tests for bleeding disorder. And there are only 5 tests as screening tests for any hemostatic disorder. Any hemostatic problem, there are 5 things that we need to do. First, history. Remember, history is a brilliant test. Like I said, if a lady has gone through normal childbirth or cesarean without excessive bleeding, a congenital hemostatic disorder is ruled out. Okay? History of similar problems in the family. Now, you may think that this is not a great thing. Let me tell you one more story. When I was a resident doing my DM, I got a consult from neurosurgery. They said there is a patient who has excessive post-op bleeding. They had done a craniotomy. And after finishing all the work at night, 11:30, 12 o'clock, I went to neuro ICU. And in neuro ICU, there was a 55-year-old man sitting. He's sitting in the ICU. He's not on intubation, I think. He's just sitting, and there is a drain coming. And I go there and I ask the nurse in the neuro ICU, nurse, there is a hematology consult. There is a patient with bleeding. And this patient who's on the bed, he hears what I say, and he suddenly shouts out. He says, Dr. Babu, I have hemophilia B. I have hemophilia B. My brother has hemophilia B. I'm telling the neurosurgeons, you are doing surgery tomorrow. I have hemophilia. And the neurosurgery resident said, shut up. What are you saying? You cannot possibly have hemophilia. And see, Dr. Babu, mera surgery kar diya, and now bleeding, and now they are calling hematologists. So, we all get so held up and stuck up in our own practice that sometimes we forget some essential screening, questions. So history is something that we spend a lot of time on, and I showed you in the previous slides all the details that you asked. The second test is a complete blood count because you want to see if the platelet count is normal. If the platelet count is low, you're not going to think of a hemostatic disorder, coagulation problem. You're going to think of ITP or leukemia or aplastic. So here, first of all, look at platelet count. If platelet count is okay, we do a bleeding time. Bleeding time is a beautiful time-tested test for platelet function if the numbers are normal. Then we do PT and we do APTT, right? Clotting time is not done in the world for the last 20 years. Clotting time is outdated, it is crude, and it has now been replaced by PT and APTT. So the 5 tests that we do for any patient coming to us with a hemostatic problem, we take history, we look at the platelet count, bleeding time, PT, APTT. If these 5 things are normal, generally the patient does not have any major bleeding disorder. So this is how we look at it. A patient is normal if their platelet count, bleeding time, PT, APTT, and the history is also negative. Okay, normal person, forget it. Nothing more is required. Platelets are low, thrombocytopenia, you're going to look for ITP, leukemia, aplastic, etc. If the bleeding time is, and of course, when the platelets are low, bleeding time is going to be prolonged. In fact, when the platelets are very low, we don't even do the bleeding time. It's going to be prolonged. So when the platelets are below 30,000, we don't do bleeding time. It's going to be prolonged. What will you get by doing it? However, there are patients whose bleeding time is prolonged with normal platelet count. In them, prolonged bleeding time means platelet function. So we do platelet function test. There is a different test called platelet aggregometry. We are not going to get into the details of that, but we do platelet aggregometry and then try to find out whether the person has one of these platelet function disorders. Okay. Or it can even be overdose of aspirin. Yeah. Normal platelet count, prolonged bleeding time, look for platelet function. Now, we are coming to PT and APTT. Okay. So in coagulation problems, so these are bleeding problems, these are coagulation problems. In clotting problems, bleeding time, platelet count is normal. The only thing abnormal is PT, APTT, or both. So if only PT is prolonged, only PT, then PT is very sensitive test for vitamin K dependent clotting factors. So there are certain clotting factors which need vitamin K for manufacture in the liver. All of these clotting factors are manufactured in the liver. Liver is the factory, right? And there are some clotting factors which are vitamin K dependent. That's required. So only PT prolonged, everything else normal. We will either think of a congenital factor 7 deficiency or something like that, or acquired warfarin, vitamin K deficiency, acetylcholine overdose. That's what we look at when isolated PT prolongation. What about isolated APTT prolongation? APTT, right? Well, commonest problems are factor 8 or 9 deficiency, that is hemophilia A or B, or a spectrum of disorders we call as von Willebrand disease. There are also other diseases, rarer clotting factor deficiencies, which can lead to APTT prolongation or combined PTVT prolongation, but we are not going to get into that. These are the common things. Normal people, thrombocytopenia, platelet function, isolated PT prolongation, vitamin K dependent or warfarin, isolated APTT prolongation, hemophilia or von Willebrand. These are the commonest, right? Now, once we have taken the history, we have done the screening test, we have understood the pattern, bleeding versus clotting disorder, we do what is called as a coagulation workup. A complete coagulation workup has to be done in a coagulation lab, not in your routine lab. You see all of these factor levels, including PTAPTT, they are biological tests. They are not chemical assays like serum potassium or serum sodium or whatever. And most of the labs in our country don't do PTAPTT properly. They don't do it. They are not trained. They don't have the standard, right? So whenever we are told that, okay, doctor, I have a patient with excessive bleeding or prolonged PT, I say, no, send the PT to our lab, which is a coagulation lab, standardized, technicians are trained, quality control is good, and the sample has to be fresh. So many times we send a blood sample to these referral labs, so many good nationalized labs. But by the time the sample reaches the lab in Mumbai or Delhi, the factor level in the blood has gone down. So you'll get a false low level. You will get false low factor 7 or factor 8 or protein C, protein S. So proper coagulation testing has to be done in a coagulation lab with a fresh sample and tested immediately within 30 minutes. Okay. So whenever we actually do such a coagulation workup, we do everything that I've told you before. And like I said, CBC, platelet count normal, look at the PT prolonged. I said vitamin K dependent and factors, that's 2, 7, 9, 10. Sorry, 2, 5, 7, 10. And or liver dysfunction or vitamin K antagonist. And treatment, of course, is you give vitamin K or FFP. FFP has all the coagulation factors. If isolated APTT prolonged, this is something else that we do. And you should understand what we do. So now we have a patient whose APTT is prolonged, more than 1.5 times normal. So the upper limit of normal is say 32 seconds and patient's APTT is 100. Then what we do, normally suppose the lab does APTT with say 100 microliter of plasma. Okay. We will now take 50 microliter of patient plasma and 50 microliter of normal person's plasma. So we mix patient plus normal control plasma. That's called half patient, half control. And then we repeat the APTT. Now, the control plasma has all the coagulation factors. It is a normal person's plasma. And when I mix, if my patient's plasma is deficient in coagulation factor, okay, and that is why APTT was 100 or 150. By adding 50% of control plasma, now the coagulation factor level would have come up, and my APTT of the patient, which was 100, when I retest it, it will look like 50 or 60 or 70. There will be partial correction. So we do APTT, then we repeat APTT by mixing half control plasma. If that corrects the APTT, means my patient's plasma was deficient in some factor which was given by the control plasma. So I will see this in hemophilia A or hemophilia B, correct? Because they don't have any endogenous coagulation factor, and this gets replaced, and I repeat it. However, if it is not correcting, that means my patient plasma had some factor inhibitor. It had some factor inhibitor. So it also inhibited the factors, coagulation factors in the control plasma, right? And that is why even after mixing with control plasma, the APTT did not normalize. Now, what are these inhibitors which can block coagulation? These are antibodies, which is lupus anticoagulant or acquired hemophilia, where in the elderly patients, it's an autoimmune problem. There can be antibodies against factor 8, right? So this is how within a simple lab, we try to figure out what is happening before we send the sample to a coagulation lab. If PT-ability is normal, platelet count is normal, only bleeding time is prolonged, we do platelet aggregometry and we figure out, is it a drug effect or is it Glanzmann's, thrombasthenia, etc. And if everything is normal, okay, platelet count is normal, bleeding time is normal, PT is normal, APTT is normal, but there is a history of bleeding, and that too delayed bleeding. That's a very specific disorder called factor 13 deficiency. Very rare, but very specific. Yeah. So that's how that's about coagulation and our approach, a hematologist approach to hemostatic disorders. Now, one single slide on transfusion of blood products as a practical guide for you, right? And Dr. Ashish Dut from our team is going to take a complete class for you. But I wanted to leave you with this because this is part of hemostasis, right? Uh, Whenever you have any bleeding patient, you please collect some extra blood sample for coagulation testing, pre-transfusion. So before you give blood or FFP or cryo or even platelet transfusion, just collect a couple of tubes of EDTA and sodium citrate, right? So a couple of extra tubes of for CBC and PT, APTT. And later on, when we come, we may say, all right, you have a sodium citrate, the PT tube. I can do coagulation factor assay on that, but it has to be pre-transfusion. Uh, you want to give blood? Sure. If the patient's hemoglobin, patient is bleeding so much that HB is less than 8 or is an intraoperative unstable patient and the hemoglobin is dropping from 10 to 9 to 8, sure, give PRBCs. But again, collect a pre-transfusion sample. When to give platelets? If bleeding is due to aspirin, NSAIDs, or congenital platelet function defects, and there is severe bleeding, you have to give platelet transfusion. Even if the platelet count is normal, you have to put in some normal platelets in the system which can stop the bleeding. Yeah. What about fresh frozen plasma? Well, this is a magic blood product. It has all the coagulation factors except, of course, platelets. And PT ability prolonged, bleeding. You don't know what is happening. You're in one corner of the world. You don't know what to do. Collect a pre-transfusion sample and give off FFP. Nothing will happen. Don't worry. Yeah. However, if the patient is not bleeding, but there is deranged PT-APTT, maybe liver failure, maybe whatever, please don't give FFP. Yeah. In medicine, in clinical medicine, we do not treat the report, we treat the patient. So FFP, etc., transfusion without bleeding doesn't make sense. Yeah. What about if a patient with known hemophilia A or B comes to you? Well, if you have the coagulation factor injection, there is a dose. You can give it as per that, or you can give FFP if you don't have coagulation factor concentrate. Many times we will have a known patient with hemophilia A with a road traffic accident or something coming to your casualty. In that, if you don't know what to give, you can just give FFP if there is bleeding. Okay, if there is bleeding. And for hemophilia A, if you have cryoprecipitate, that is preferred because it's more concentrated. And if you give too many FFPs, there can be fluid overload. So that's it from me for basics of coagulation, the theory, the approach, and transfusions. I'll be happy to take questions if I.
So it was very nice, sir. I have a doubt.
Yeah.
Uh, so you said when there is a break in the endothelial, the tissue factor is going to be released.
Hmm.
And the coagulation cascade will start and the coagulation starts.
Yeah.
So, and what makes the coagulation to stop?
Oh, lovely. So, lovely question. So, what we did not touch upon is we did not touch upon the anticoagulant pathway, right? So, the protein C and S and all that, we did not touch upon that. And what makes it stop? I don't think we fully understand. What makes the clot break down? Fibrinolysis, right? Now, mind you, in all of these, this leads to that, that leads to that. It also activates it also activates prothrombotic, antithrombotic, fibrinolytic pathways. So the tissue factor, plasminogen inhibitor, etc., all of these are activated. And somewhere a balance is reached that if there is a clot, bleeding has stopped, further clot generation slows down and breakdown of the clot starts because ultimately the blood flow has to start again. But we did not get into the details of that. That's a good question.
So there was one patient, I saw him maybe around 15 years back.
Okay.
Hello.
Yeah.
And actually, this child, he came with, epistaxis,
Mhm.
very severe epistaxis. And the amount of blood he used to consume, so that irritates him to vomit. And he used to vomit, at a time, kidney tray in my clinic used to fill it up. So immediately this patient was referred to St. John's at that time.
Yeah.
And they did all the investigation, basic investigation, and all the reports was normal.
Mhm.
So finally termed as a functional disorder. But at that time, even it was not tested for what functional disorder was
Yeah.
existed for that. So
It's
finally they said go to CMC Vellore.
hmm,
So this patient, I think, went to CMC Vellore and he doesn't have any reports. So right now he is around 19 or 20 years boy. So can we do any testing, as you said, to
yeah,
confirm what is the cause for that?
yeah,
Because right now the severity of bleeding has come down, but occasionally he says he is having some, spontaneous bleeding.
yeah. I trained in CMC Vellore and we had the best coagulation lab in this part of the world. Dr. Sukesh had created it and he's truly a phenomenal, uh, uh, you know, um, expert in coagulation. And I passed out in 2011 and 2011 till now, so many new proteins and so many new tests have come up. So there were patients where previously we could not diagnose any hemostatic defect. And now, we can. Not only that, we can also do genomics. So we can do a clinical exome on your patient, for example, and look for sometimes, just the mutation directly. So yeah, it would be great to see your patient, Dr. Bhaskar, and you could send him to our center in Bangalore, and let's see
Okay.
if we can figure out what's happening.
Because recently when he came, I said, you're already 20, maybe another 2, 3 years you have to get married. So before that,
Yeah,
get your workup and then you plan for
yeah.
the marriage. That's what I told them. And
That's
suppose if there is a family history of hemophilia, so what screening test to be done for the other siblings, anything like that?
So that's a very important question. And not only hemophilia but Glanzmann's. I have had when I was in CMC two families with Glanzmann's, and then hemophilia. You have to do APTT, but you have to also understand the genetic transmission. So you have to understand whether it's an autosomal recessive disorder, whether it's an X-linked disorder. So hemophilia A is X-linked, right? And it goes from mother. So mother is the carrier, and but the mother is not affected because she has two X chromosomes, one normal and one mutated. So the mother's APTT is slightly prolonged. She may have some menorrhagia and postpartum bleeding, but largely mothers are okay. But when the mother gives birth to a son, right, the son may get the defective X from the mother, and then the son becomes a severe hemophilia A. So it's a bit complex. I don't know if we have, Dr. Soumya, do we have a talk on hemophilia and some details of coagulation problem? If not, I could take that because this is a very important question and we should address it. We can, whenever anybody with hemophilia A, for example, comes to us, we do family screening and we do genetic counseling. So if his mother or his sister is a carrier, then intrapartum, if they need a cesarean, they are like the mild bleeding coagulation disorder type. So they may need some cryoprecipitate transfusion. So it's a whole different thing, managing hemophilia. If we don't have a class on that, I'll arrange one for you.
Please, sir. I have a patient for that.
Yeah, yeah. And just call me and let me know when they want to see. And I would love to see these patients. Yeah.
Okay. Thank you, sir.
Pleasure. All right. Next question.
So this umbilical bleed, prolonged bleed, how many days we can wait before testing for this, factor 13?
Oh, we don't wait. So anything unusual. So, it's very obvious. I mean, common laymen can make out, sir, itana bleeding to hota nahi hai. So anything unusual, it is better to test early rather than delay. Yeah. Any bleeding that does not stop within a few minutes, any bleeding that requires surgery or suturing, any bleeding that requires transfusion, you should not delay.
Okay. Thank you, sir.
Sir, one of my friend relative, she diagnosed as a hematohidrosis. Hidrosis. So she's having the bleeding from all the openings. Like if whenever there's increased sweating, also she's having some bleeding. So they did all the hematological evaluation and bleeding disorders evaluation, but everything was normal. So initially we thought it's a psychological things, but finally that from Ramachandra Medical College they diagnosed as hematohidrosis. Is there is anything can be done for
No,
this?
I've not heard of this disorder, Dr. Kingsley. See, hemosidrosis or hemochromatosis is a different disorder. I don't know what you're saying. Why don't you send the patient's reports to me and we'll go through it?
Sure, sir, Vixen. Thank you.
Any other question? Yeah, Dr. Shirisha.
Sir, for patients who are on warfarin, is it enough if we check PT, or generally who are on warfarin, we generally check PT, APTT regularly? How often should we check, monthly, or is it enough if we check PT alone?
I don't know, yeah. I mean, warfarin and acetylene have been given for donkey's years. Patients who are stable, some patients have a stable INR. If your target is an INR of 2 to 2.5, they're between 2 and 2.5. Most of the time, you can see them once in 6 months. There are some who are very unstable and the INRs will widely fluctuate. Sometimes it will be 1.3, sometimes it will be 3.5. Those patients you have to see more frequently. Typically, once you have changed the dose, you should wait for at least 1 week to repeat the INR. But it really depends on the patient. Nowadays, because of this issue, most of the clinicians are preferring the newer oral anticoagulants where you don't have to monitor INR.
Sir, I heard that for cardiac patients, we cannot give newer anticoagulants. Is it so, sir?
Oh, that's
For
not true.
MR, mitral regurgitant, like.
So it depends. Again, cardiac patients, we don't manage. As far as atrial fibrillation is concerned, my understanding of the research is newer oral anticoagulants are also good. What about prosthetic valves? I really don't know. Those patients don't come to us. They typically go to the cardiologist. But atrial fibrillation for sure, newer oral NOACs are as good as warfarin or acetylene, as far as I understand.
Thank you, sir.
Sir, how reliable that bleeding time we are doing that capillary method, no, sir? But
No. No, bleeding time is done by cutting. So you need a scalpel and
Yes,
you know,
yes, sir.
so we have to train, not every technician can do it. So wherever we start a department, we train 1 or 2 technicians to do it properly, because if they poke in too deep with the scalpel, there will be too much bleeding, right? Even in a normal person. So it has to be taught. I mean, in general, PT, APTT, bleeding time, we have to ensure that the technicians know how to do it properly before we depend on the reports.
Okay. So apart from that platelet aggregometry, is there is any test to detect that platelet function abnormality like Glanzmann or Bernard-Solier or platelets?
So there are newer methods of doing platelet aggregometry using flow cytometry. And of course, we can do genomics.
Okay.
It's interesting, we are going into quite a bit of details. I wanted to keep this superficial. I didn't want to tax your brain with details, but it's interesting that you, all of you already have so much knowledge and interest, and you're pushing me to get into more details. It's exciting.
It's because of you, sir.
No, it's good fun. All right. I think we are done with the questions. I've already shared the PPT
Sir,
and
acquired factors deficiency. That's what APLA, no, sir. Sir, I want to know about that. It's
so
about the bleeding disorder or clotting one, sir.
exactly. See, APLA, the APTT will be prolonged, but instead of bleeding, the patient will present with clotting. So it's a thrombotic disorder, right? And yeah, that's it. APLA is more of a thrombotic disorder than anything else.
Sir,
My
is it common in females or equally affected, sir, males and females?
no commoner in
Usually, we seen with multiple abortion history and
yeah.
all, but
So
males.
there are two things. See, it's commoner in females, but when you are looking at APLA in the context of multiple abortions, uh, you see, we don't really understand what causes multiple abortions. We don't understand biology of of conception and fetus. Yes, APLA is one of the things, but there are very strict criteria for diagnosis of APLA syndrome leading to multiple abortions, right? So you have to repeat the testing after 4 to 6 weeks, and there have to be so many first trimester or second trimester. So most of the time we just say, yeah, lupus positive. No, if we are going to attribute pregnancy loss to these disorders, then we have to ensure that the criteria are fulfilled. Otherwise, what happens is we think, no, lupus positive. Next pregnancy, we will give aspirin, we'll give low molecular weight heparin. And if there is again a pregnancy loss, then the woman says, madam, we gave everything this time, but still there was pregnancy loss. So we have to see, does that patient really have APLA related pregnancy loss or not? Does the patient fit in the criteria or not? The criteria are very important.
So they present with thrombotic episodes, and again we have to treat with heparin.
Yeah.
And APTT is already prolonged, no, sir?
Yeah. So how to monitor?
Yes, sir.
We can't. So again, that's complex. I'm not going to. So thrombotic disorders are a different spectrum altogether, and maybe we'll take a talk on that. All right. Thank you, guys. Thank you so much. Like I said, the PPT is in the group. The question paper is in the group. I will share the recording probably by tomorrow evening. Yeah. Thank you so much.
Thank you, sir.
Yeah.
Thank you, sir.
Thank you, Dr. Sachin.
Thank you.